Hello, thank you very much. I'd like to thank the organisers for the opportunity to present here on behalf of the AFRICOS study team. So I have no conflicts of interest to declare. AFRICOS is a very early, or it's a junior study, still in its infancy. We have some preliminary data that I can present, but I'm going to discuss more the methods of this study, but also I want to focus particularly on how cohorts such as AFRICOS are a very useful program implementation tool and a tool for monitoring the quality of programs. In general, I think there's a need for more non-interventional prospective observational cohorts to provide information on the real-world impact of our programs and interventions. Cohorts have the power to provide granular level patient outcome data, which a lot of our quality tools and monitoring and evaluation tools are unable to provide us. The outcome data informs program strategy and has can inform health policy, and we can also, with long-term cohorts, monitor how changes in program strategy and implementation can impact on patient outcomes. They can provide a benchmark by which we can measure other program monitoring tools, and they can produce early signals for events such as toxicity, emergence of resistance in a community, and other emerging health concerns. So the African cohort study is a prospective observational HIV-focused cohort with a broad primary objective, which is to longitudinally assess the impact of clinical practices, biological factors, and socio-behavioural issues on HIV infection and disease progression in an African context. It's also used as an evaluation tool in real time for the MHRP PEPFAR program. And it does gather research data that can be more generalizable towards HIV pathogenesis and impact on comorbidities. It has a projected 15-year study duration. It's currently enrolling adult volunteers in the care and treatment setting. The goal is to enroll 3,000 HIV infected and 600 uninfected subjects. And it leverages the international clinical and laboratory research expertise of the MHRP network. So currently we are enrolling in 11 HIV clinical care and treatment sites across 5 programs in 4 countries. So those programs are the Makerere University Walter Reed program in Uganda, the Kemry Walter Reed program in Kericho in Kenya, the Kemry Walter Reed program in Kisumu West in Kenya, the Walter Reed program Nigeria, and the Walter Reed program Tanzania. So you can see that it has quite a wide enrollment geography. Most of the clinics are in East Africa with two enrollment sites in Nigeria. HIV infected volunteers are recruited from clinic lists. Existing clients and new referrals are taken. Uninfected volunteers are usually serodiscordant partners or identified at counselling and testing sites. There's an enrolment visit, which is very comprehensive, and then 6 monthly follow-ups with unscheduled visits for acute illness. Subjects undergo physical examinations, questionnaires with demographic, social, and medical history, including obstetric histories. HIV outcomes are examined using clinical staging, CD4 counts, viral load, genotypic resistance testing at baseline and at virological failure. HIV uninfected volunteers are assessed in the same manner but undergo routine HIV testing, obviously, rather than monitoring of HIV outcomes. PBMCs, plasma and serum are reposed with each scheduled visit. So I don't want to go into this in too much detail, but just to highlight that there is an extensive laboratory assessment at each visit, and we also include neurocognitive batteries, functional assessment and depression screens. Currently we are a little over halfway to full enrolment with 1,493 HIV positive subjects, 319 negative. This is data that was presented at CROI this year. when we look at a preliminary analysis of comorbidities in the cohort of 1,130 subjects, we can see that there's quite a high instance, especially of non-infectious comorbidities in our cohort, with hypercholesterolemia, impaired fasting glucose, elevated blood pressure, and anemia all being represented. Amongst the infections, we can see that syphilis and cryptococcosis, as defined by a elevated serum cryptococcal antigen, is seen in 8.3% of individuals with CD4 counts less than 100. So again, just to highlight that the rate of non-infectious comorbidities is approximately 50% for at least one, and infectious comorbidities is lower, but these are 6 monthly visits, so it's likely that we are missing interim infections. So how does this inform our program? We generate dashboards from our program data on a regular basis that we can look at and examine how we are doing as a program, and especially how we are doing with respect to virological outcomes within the programs. We use a color coding for our dashboard, similar to if people are familiar with the SIMS tool, which I'll touch on a little bit later. But we use a dark green for greater than 90%, for example, for viral load suppression, light green for 80 to 90 or 80 to 89, yellow for 60 to 79, red for less than 60%. This is a most recent dashboard looking at all sites. The N here is 1,071. We can see that it's stratified according to CD4 count, and this is all sites, so it's giving us the whole picture of the cohort, but we can break this down into individual sites for programmatic reasons. Just looking at this data, what was interesting to us is that on enrollment, so these are individuals who are new to the study, for CD4 counts greater than 350, the individuals presenting on ART did have over 90% were virally suppressed. On the other hand, for individuals with CD4 counts less than 200, most of these, or only 57% less than 200 were suppressed. These had been on ART for a mean duration of about 3.1 years, so they're not new to ART. When we look at the number for on ART, however, when we look at those who present with a CD4 count less than 200, not on ART, the mean duration since diagnosis to enrollment had been 1 month. I think of particular importance when we were looking at this information is that of those with a low CD4 count who are virologically failing on ART, only 3 out of the number, the N here would be 45, were on second-line therapy. This is the second visit, so 6 months later, and we can see that this most likely reflects the intensification of treatment and laboratory evaluation that these subjects received due to the activities of the cohort. I just want to briefly touch upon how these cohorts such as AFRICOS can complement other program activities. So the site improvement through monitoring system is a PEPFAR-wide initiative. It has primary objectives of monitoring capacity at sites, above sites, to provide high quality HIV/AIDS services in all program areas. It's implemented by US government agencies and partners at a site level to identify and remediate system capacity deficits. The results are similarly presented in a color-coded dashboard. And when we look at our sites, we can see that just to explain SIMS briefly for those who are not familiar with it, SIMS has a number of, this is a facility tool, it's a quality assessment tool. It involves about, I believe, 24 domains with over 112 subdomains, and these domains are scored to allow for remediation. So I don't want to go into the detail of the domains, but just to show that when we looked at how this quality tool scored our sites, our AFRICOS sites, you can see that most of them did reasonably well, but facility D and E there have a lot more red than the other sites. Now, when we looked at our AFRICOS data, these two were the lower performing sites in the cohort. However, conversely, when we looked at the well-performing sites, there wasn't such a clear correlation. This facility A here did extremely well under the capacity monitoring and quality monitoring of SIMS. However, when we looked at the AFRICOS data, again, we had a similar picture to what I presented earlier, with individuals at low CD4 counts failing therapy. Here, 33% only were virally suppressed, although this is a low number. And these subjects have been on therapy for a duration of about 6.1 years on average. So just to summarize, so cohorts can provide granular data on patient outcomes. They can answer questions that a lot of our quality tools cannot, such as are patients receiving appropriate antiretroviral therapy, not just are they receiving antiretroviral therapy, are they being switched appropriately when they're failing. It can give us detail on adverse drug reactions. We can look at our quality tools and see do they correlate with patient outcomes, and we can see does remediation impact on our cohort. So the intensive focus on subsets that cohorts can allow facilitates precise data gathering on these bottom line outcomes. The limitations of this cohort are that often when we are enrolling cohorts, we enroll easier to enroll individuals or those that are willing to enroll. They may be more adherent subjects. We're focusing on high volume facilities. This is not necessarily generalizable to lower volume facilities. And in this particular cohort, the subjects are undergoing more intensive laboratory and clinical monitoring than we would expect to be happening on although it would be consistent with current guidelines, it is not our experience on the wider program that this is what is happening. And in fact, some of our programs, countries have not even, are not even doing viral load monitoring. So I'd just like to acknowledge the assistance of the wider AFRICOS team, particularly Dr. Tiffany Ham and Lieutenant Colonel Julie Ake, who assisted me with putting this presentation together, and of course the volunteers. Thank you.